So it's my great pleasure now to introduce our keynote speakers for the session today. And there are going to be two presentations. The first is from Professor Rob Shepherd. And Rob is very kindly going to share with us his work on bionics. He's the director of the Bionics Institute and a professor of medical bionics at the University of Melbourne. So would you welcome Bob to the stage?
Thanks very much, Nigel. Thanks very much, Nigel. The Honourable Jillian Skinner, the Honourable Kevin Humphries, and importantly, the awards finalists for the New South Wales Health Innovation Awards are going to be held tonight. It's a great pleasure to be here, particularly for a Victorian to come to Sydney and talk about some of the work we're doing in the field of bionics. So our institute is an independent medical research institute that's located in a hospital. We deliberately had our location in a hospital setting in order that we spend a lot of time with clinicians. It's no use engineers and biologists and scientists working away trying to develop these type of technologies without having that vital clinical input. The vital clinical input must be there from day zero. So our three areas of research are bionic hearing, cochlear implants, neurobionics, which is central nervous system devices for epilepsy and deep brain stimulation, and bionic vision. And I'm basically going to just introduce the concept of medical bionics and then talk a little bit about the development of a cochlear implant and what we're doing now with bionic vision. So bionics is a combination of biology and electronics. It's inherently multidisciplinary. And this multidisciplinary theme that Nigel was talking about will come back again and again when we're talking about innovation. So there's a large number of clinical devices that many of you already know, all of you know, that are very, very successful in making very important health outcomes at the moment, including heart pacemakers, cochlear implants, and deep brain stimulators for motor disorders. But also on the horizon, there's some really, really exciting new medical bionics devices. They're in the pipeline to clinical application, and they include functional electrical stimulation to allow paraplegics to stand for short periods of time, brain-computer interfaces to allow quadriplegics to control a computer cursor or robotic limb, DBS for example, severe psychiatric disorders, vestibular prostheses in cases where people have severe balance disorders, and retinal or visual prostheses. So I'm going to talk about two devices that have gone through this regulatory pathway and are available now commercially. The first is deep brain stimulation for movement disorders. And this technology is technology that's sold by companies out of the States, and they involve implantation via neurosurgeons deep into the brain of patients with a variety of different movement disorders, usually associated with Parkinson's disease.
The probe that is placed into the brain, I understand, comes level with the top of the nose and the ear, and it is connected to a battery in my chest, underneath the skin in my chest here, and this is controlled. I can control the amount of the voltage going in, I can control the length of time that the pulse is, and I can identify the number of times per second that it goes in. And I'll turn myself off now.
He can remotely turn himself off, so his stimulator stops stimulating.
So one of the problems, not only as you can appreciate, is that you can't do very much for yourself. All personal hygiene is but because my concentration now is up to 90% of my tremor, I'm trying to control it. And I'm thinking the word Parkinson's all the time. I'm not terribly... I'm not concentrating on my conversation with you at all.
So he's going to turn his device back on.
Okay.
The little stimulator unit is located under the skin over the thoracic cavity.
You can see this quite...
So DBS devices provide alleviation of some of the symptoms. They certainly do not cure diseases like Parkinson's disease, but they alleviate many of the motor disorders that are associated with these devices and really revolutionise the life of patients like this gentleman. So I'll spend a little bit more time talking about cochlear implants because cochlear implants are really an Australian invention. And this was a situation in 1967. This is a letter from an otologist to his profoundly deaf patient. And you'll see that really the otologist didn't offer much hope for the patient. There was really nothing the otologist could do. In concluding that, that you will make the worst of a pretty bad lot, the most of a pretty bad lot. So these patients, these profoundly deaf patients were destined to go into a signing school and learn sign language. But in the early 1970s, there was enough underlying fundamental science about the understanding of the auditory system. There was some clinical trials around the world, some very, very basic clinical trials around the world to demonstrate that if we electrically stimulated the hearing nerve, patients could perceive some form of sound perception. And importantly, engineers were developing integrated circuits that would be low power and could be implanted in the body. And there was a real clinical need. 120,000 patients in Australia alone were profoundly deaf. And importantly, there was no competing technologies. So the 1970s saw the development of cochlear implants not only in Australia, but also in a number of laboratories around the world. And this is our laboratory, a pretty motley crew, I might say. This is a department of otolaryngology. There's 2 otologists in this department. It is a multidisciplinary group. There's biologists, there's engineers, there's psychologists, there's physicists, and importantly, there's clinicians. You know, you'll probably recognise some people. There's Graham Clark. This fellow here is the chief scientist of Cochlear, Jim Patrick, and your speaker had a little bit more hair in those days. And of course, with every innovation, there's naysayers. Every innovation will have naysayers. You can't do it. So Merle Lawrence was one of the great auditory neurophysiologists of the time and made this very, very clear statement that electrical stimulation of auditory nerve fibres is not going to result in perception of speech. It's not feasible. Forget it. We have to be thicker than that. We have to ignore the naysayers because there'll be a line of them. You just keep on going if you think your project, your innovative project is correct. So this is the basic device that was developed in Melbourne and implanted in 3 patients. We called it an aid to lip reading. We never envisaged that, as happens now, people use it on a mobile phone. They use it without lip reading cues. We use it with a handheld microphone, and it was like a reporter. Patients obviously didn't like that, but the technology demonstrated proof of principle that we could electrically stimulate the hearing nerve and patients could perceive human speech. From then, the technology was taken out of a university environment and commercialised by Cochlear. And this now is the Cochlear implant that many of us know and is probably the leading medical bionics device in the world. And it's manufactured in Cochlear here in Sydney, less than 10 kilometres from here. So the electrode array is inserted into the inner ear and stimulates a variety of different auditory nerve fibres, and the external speech processor sits on the pinna, and communication between the external device and the implanted device is achieved wirelessly through the skin, so there's no wires coming out of the skin. That's important from an infection point of view. This video shows patients being switched on for the first time. These people have never heard before. So what are some of the paths to success for the development of a cochlear implant? There was an excellent multidisciplinary research and development team, not only at a university or medical research institute, but certainly commercially at Cochlear. We had champions in research, we had champions in commerce, and we had champions in the government, all helping to drive the project. It was also obviously a project that inspired people. There was a large population of potential patients. As I said before, no therapeutic competition. You have to ignore the doubters. And importantly, and sometimes we don't admit it, but importantly, it's luck and hard work. One of the aspects of luck was one of our university devices failed the day of an important press conference with our patient. This patient, as luck would have it, was a real raconteur. While we were all shaking in our boots, he was quite happy to go out to the press and tell them how wonderful his device was and convince them that he was still hearing from the device without hearing a word. So luck plays an important part in the development of these devices. And as a result, we now have a company, Cochlear, which has 2,400 people, very highly skilled people. It dominates 70% of the world market in cochlear implants. It's, as I said, the most sophisticated medical bionics device in the world. Makes a very healthy profit, and it's only 30 years old. So we and a number of other colleagues, Nigel Lovell, who you'll hear from shortly, are now taking our next adventure. And our next adventure is to develop a retinal prosthesis. This is part of a group called Bionic Vision Australia, where there's partners from University of New South Wales, Centre for Eye Research Australia, NICTA, University of Melbourne, and the Bionics Institute. And even with those names, you understand that it's a multidisciplinary research project. And what we hope to do is be able to provide blind patients with basic visual cues for them to move around in everyday life, to avoid dangerous objects, to be able to pass through doors, using much the same sort of principles as been established with cochlear implants. So the target population is patients with retinitis pigmentosa. Their eyesight is failing. In 5 years' time, they'll be legally blind. In 10 years' time, they'll have no useful vision. But the cruelest thing of all, that in 20 years' time, their children might start to begin to lose their vision. So the retina is a very complex but very impressive structure that lines the back of the eye, the brown tissue in this image. If we take a high-level micrograph, you can see the different layers that make up the retina. The blood supply behind the retina, which supplies this very metabolically active tissue, and the sclera, that's the white of the eye. For some reason, we've painted it blue here. In diseases such as retinitis pigmentosa and age-related macular degeneration, the photoreceptors in the back of a retina degenerate. But most importantly, the retinal ganglion cells, the cells of the optic nerve, generally stay intact. And that's very exciting for someone that works in neural prostheses, because it means the neurons that we want to stimulate are still there. So we can provide insert an electrode and stimulate those neurons to generate action potentials so these patients can see basic visual cues. So this is what we hope to develop. We haven't developed it yet, but smart pair of glasses with a video camera, a visual processor rather than an auditory processor, a cochlear implant-like stimulator that's implanted behind the ear, and a lead wire system that runs to electrodes that are implanted just behind the retina. So here's the lead wire system to electrodes implanted just behind the retina. So we can stimulate any one of these 100 up to 100 electrodes and evoke different visual percepts for each of those electrodes. So we're working, and our colleagues at the University of New South Wales are working with materials that have proven through work with cochlear implants. They're using medical grade silicon and platinum electrodes. And we're doing that because that's a fast path to regulatory approval. There's plenty of good new materials that we could use, but if they haven't gone through regulatory approval, it's a nightmare to get them through regulatory approval. So while we're developing other technologies in the background, we know that this technology will pass through regulatory approval if it's successful in clinical trials relatively quickly. We've developed the surgical technique, and this is not locking surgeons in a room with a scalpel and some dummy electrodes and saying, please go and develop the technique. This is months and months of work going back to the drawing board, tweaking the design and making sure the design is appropriate from a biomechanical point of view and from a surgical point of view. So the surgical technique looks very simple, and compared with other retinal prostheses, it is. The surgeon creates an incision in the sclera behind the eye, creates a tissue pocket between the sclera, and then inserts our planar electrode back towards the back of the eye so it's lying close to the optic nerve, and importantly lying close to the neurons that we want to stimulate. And then very, very carefully sutures this incision. This works very, very well, and it's very, very effective. And it looks very simple, but it took a lot of multidisciplinary research to generate that surgical procedure. One of the advantages with retinal prostheses is you can actually see the electrode array when you look through the eye. So this is an image the retinal surgeon took after implantation in an animal model, and you can see the optic nerve here, and this is the retina with its blood vessels, and here's the outline of our electrode array. And we can come back and back and back again and again and again over a 3-month implantation period and demonstrate that the electrode is mechanically very stable. It is not moving over time. That's very, very important in terms of optimizing the surgery and optimizing the design of these devices. We don't want these electrodes to move over time. Movement can cause damage to tissue, but movement can also mean that one day we're stimulating with a particular electrode one group of neurons, and the next day, because it's moved, we're stimulating another group of electrodes. So mechanical stability is a very important issue. We also have to do preclinical trials to make sure it's biocompatible. So here's a histological image of one of the eyes. Here's the optic nerve, the optic disc is here. And you can see this tissue, this pocket here where the electrode was located. Higher magnification, this is where the electrode was located. Here's a retina structure here, here's the blood vessels, and this is the sclera. When we look at these over long-term implantation, the tissue reaction is minimal, the retina is normal. We have a device that, from a preclinical point of view, that we believe is safe to implant in humans. But it's not all rocket science. Some of it is extremely, extremely basic. We came from an approach where we put an electrode into the inner ear of the cochlea. Now, any of you that know the anatomy of the inner ear know it's in the hardest bone of the body, the temporal bone, and there's no movement. When we started talking to our colleagues, our retinal surgical colleagues, they were telling us that the human eye moves 150,000 times a day. After we got off the floor, we said, well, obviously it doesn't move so much in a blind patient. 150,000 times a day, macro and microsaccades in a blind patient. So we were very worried about the movement and its effects on this little cable, because in this cable are 24 platinum wires that conduct the electric current from the stimulator to each one of those little platinum electrodes. And each one of those wires is thinner than a human hair. So what happens when we subject this to long-term movement? So this is what we do. We have a lot of fun in the lab. We develop a bench test. We've got our eyeball that's moving, the same rotation as a macrosaccade. We've got an electrode attached to the eyeball, and here's our lead wire system, simulated in the surgical procedure. This has been moving like that since before Christmas. It's done 10 million flexations. Not one of those wires is broken, which gives us confidence that this type of design will be suitable for at least 20 years and counting of human implantation, because of course this is an accelerated test. This video tells us what patients might see. When we stimulate individual electrodes, we hope to get nice, clean phosphenes, these little bright dots. As we increase the number of electrodes, we believe that we can put more and more meaningful images together until we get up to, say, 1,000 electrodes, where we can create something where patients can see both large font print and potentially facial recognition. Because when we talk to patients, the number one objective with retinal prostheses is to be able to identify their loved ones. We're still a long way from achieving this, but we're making good progress. This patient is our first patient implanted with a prototype device, so she's not allowed to walk, she's not able to walk around in the street yet. She's in the laboratory providing us feedback about how these devices work, and that's a very important part of this whole research program. Matt, could I have that video, please?
It was really funny when it was switched on. I was, waiting. I had these goggles on, and I didn't know what to expect. It was just, and I don't know if anyone did know what I was going to see. And then all of a sudden I went, yep, I could see a little flash. And it was like a little, I suppose, a splinter, and there were different shapes and dark black and lines of dark black and white lines together. Then that turned into splotches of black with white around them and cloud-like images. It was just, I can remember when the first sort of bigger image came there, I just went, wow, because I just didn't expect it at all. It just, but it was amazing.
So we've still got a long way to go. We imagined we'd be able to provide nice spherical white discs, and she's talking about clouds. So there's still a lot of work that we, as a group, as a BVA group, have to do to be able to take the images that she's describing and paint them into a picture in real-time life. But we're making, I think, very good progress. So what do you need to develop these sorts of devices? Well, as I said before, you need a multidisciplinary team. You need engineers, sciences, clinical sciences, and social sciences. It is really a multidisciplinary team. But here's the most important member of a team: the patient. We must never forget the patient. We must always talk to the patient about what they expect out of these devices, and we must not engineer for engineering's sake because we enjoy it. We must engineer to make sure we develop a device that is useful to the patient. The other issue, particularly for these sensory prostheses, for cochlear implants and for visual prostheses, is that we acknowledge that we present a very, very crude stimulus to the hearing nerve or to the visual nerve. And what we need to do is make sure that that basic stimulus is providing some significant behaviourally relevant information to the patient. although it's a crude stimulus, we believe that the plastic brain will then become more plastic and be able to adapt to those fairly crude stimuli that we're presenting. And we absolutely know that's the case with cochlear implants patients, and we're hoping it's the case as we develop a sophisticated retinal prosthesis. So that's our team at the Bionics Institute in Melbourne, and many of them were also associated with cochlear implants. And they're our clinical and research collaborators, including colleagues from the University of New South Wales. So thank you very much.